Shoham. I'm an interventional pain physician, anesthesiologist at Apex Spine Institute. And today we're going to talk about spinal cord stimulation for painful diabetic neuropathy. Talked about this last year for those of you that were here. There's some updated information that we'll talk about today, just to kind of show you how things have progressed as far as the studies on this. And so here we go. Disclosure, no conflict of interest to disclose. A little bit about my practice. So we have a comprehensive pain center here in Richland, Washington. We offer interventional pain management. That's what I do. My partner, Dr. Sahota, is an orthopedic spine surgeon. And we have a total of 8 medical providers. We have some nurse practitioners and physician assistants that work with us. We have an imaging center. We have X-ray as well as an MRI for our patients. And we have an outpatient surgery center. That's where we do most of our interventional treatments and spine surgery. We also offer medical pain management for those patients that need it, both non-opiate and opiate pain management if necessary. So a couple of questions I'm going to ask that I asked last year, and I'm just going to see if anything's changed in the past year or not. But who here has patients with painful diabetic neuropathy? Just show of hands. All right, so that for those of you that aren't here online, there's a majority of people raise their hands. And who here has used medications that treat painful diabetic neuropathy? Okay, good. So it's common and people treat it with medications. And who here has referred a patient for spinal cord stimulation for painful neuropathy? Oh, all right. Last year there were no hands. I saw 3 hands go up, so we're making headway. That's great, and that's why I'm here, frankly, is because this is a patient population that really has not had their needs met, and this is a really effective treatment, probably the most effective treatment if you look at the data. And I just want to make sure that these patients are at least offered this as an option if they meet criteria. So objectives of our talk, just to kind of understand that painful diabetic neuropathy, it's a progressive and debilitating disease. Many patients are suffering from just conventional medical management. And spinal cord stimulation, it's relatively safe. It's an effective long-term treatment for those with painful neuropathy. And that's the data that I'll show you today. Spinal cord stimulation is proven to reduce pain, improve mood, improve the ability to sleep with a high patient satisfaction rate. If you talk to these patients that have painful neuropathy, one of the biggest complaints is sleep. These patients just don't sleep. Their legs are on fire when they lay down. The sheets feel like hot burning coals on their feet. It's miserable, and these people are suffering. So basically, I want you to consider a referral for spinal cord stimulation as a treatment option for patients that have refractory painful diabetic neuropathy despite conventional medical management. So a little bit about painful diabetic neuropathy. As you all know, most of your patients are probably diabetics. It's very common in our patient population. About 11% of Americans are diabetics, and 20% of diabetics will develop painful diabetic neuropathy. Distal symmetrical polyneuropathy is the most common form of diabetic neuropathy. And diabetic neuropathy, it leads to basically the gradual loss of the integrity of the longest nerve fibers. So symptoms usually begin distally in the toes, and they are symmetric. And symptoms include numbness, tingling, neuropathic pain. Again, starts in the toes and feet, migrates proximally in a stocking distribution. About half of the patients with diabetic neuropathy develop painful diabetic neuropathy. So painful diabetic neuropathy is not just the numbness in the feet. And many patients have that numbness, but we're talking primarily about the pain. And that's what we treat with spinal cord stimulation. It's interesting, we'll talk a little bit about the sensory issues and how stimulation may actually reverse some of the sensory deficits, but painful neuropathy is really what we're talking about here, not just diabetic neuropathy. Again, it's progressive. It usually gets worse over time. People get extremity pain, paresthesias, burning, shooting pain, worse at night, disrupts sleep. Sleep is really an issue. If you actually talk to these patients about it, they don't sleep. And the targets for painful diabetic neuropathy are primarily pain management and glycemic control. The thought is that glycemic control will mitigate nerve damage that's progressive, but we really don't have great treatments for it. There's no disease-modifying treatments thus far, but we're going to talk a little bit about how stimulation may actually be at the frontier of some changes here. And progressive symptoms, they're debilitating, and extremity numbness and progressive deterioration of the sensory nerves in the feet, it increases fall risk. And you get that loss of protective sensation. Patients get foot ulcers. They don't walk as much. They have all the vascular issues that come along with that, amputations and increased mortality. It's this vicious cycle. So what do we do to treat the painful neuropathy? A lot of you probably know this very well. First line agents are gabapentinoids. So gabapentin and Lyrica are commonly used. Sometimes serotonin norepinephrine reuptake inhibitors like duloxetine and venlafaxine are used. Tricyclics are sometimes prescribed as well, and some patients need management with opiate medications if they fail these other measures. When you look at how effective the medical management we provide these patients are, it's really not great. So, a meta-analysis looking at randomized controlled trials for neuropathic pain showed that the number needed to treat to get 50% pain reduction in one patient is 4 to 11. So you may need to treat up to 11 patients just to get 50% relief in one patient. And if you think about that, a lot of these medications, they have side effects. A lot of these patients, they're old. You give them gabapentin, you give them Lyrica, it causes fuzzy mentation. And I'm not saying not to use these medications. These are first-line therapies, and for some people, it really does help. But they do cause side effects. And even if they do get pain relief with that, they're getting some negative effects on their quality of life and their mentation and their cognition. Again, the gabapentin and Lyrica are commonly prescribed, but as you know, long-term adherence is poor. More than half of the patients stop by 6 months due to either side effects or lack of efficacy. Duloxetine or Cymbalta also has a similar pattern, about 50% of patients stopping by 6 months. And either insufficient pain relief or side effects from the medicines, it leads to long-term poor compliance with the medical regimen. So what happens is most of these patients, they don't really switch to another therapy, or they're not offered any other options, and it leaves their pain condition really untreated. And this represents a ton of patients that really have severe pain with unmet needs. So a little bit about spinal cord stimulation for painful diabetic neuropathy. It's an effective treatment for patients that have pain refractory to medical management. This isn't something you start with, right? A lot of these patients have been suffering. On average, most patients I see have had this for about 7 years or so. So this is not something that just came on yesterday that we're doing stimulators for, but they need to have the pain for at least a year and fail medical management. And basically what I do is you place leads in the epidural space and we stimulate the spinal cord electrically, and it changes people's perception of pain. There's a lot of different mechanisms of action that have been proposed, but you can kind of think of spinal cord stimulation like a medication. You can adjust it, and you can adjust the amplitude of the stimulation. You can adjust the pulse width. You can adjust the rate of the stimulation, and you can also adjust where you're stimulating along the spinal cord. There's various electrodes that you can stimulate. Here's just an animation that shows a little bit about the mechanism. Let's see if I can, oops. There it is. Yeah.
Right.
Very tech savvy. Do you know how to,
Yes.
there you go, shift something.
And
Beautiful. Yep.
Chronic pain can arise from numerous conditions and have many negative impacts on a person's life. Hyperactivity, the wide dynamic hyperactivity.
I'll just rewind it a little bit.
Chronic pain can arise from numerous conditions and have many negative impacts on a person's life. Hyperactivity in the wide dynamic range neurons, or WDRs, which project pain signals to the brain, is believed to contribute to chronic pain. The goal of spinal cord stimulation is to suppress this neural hyperactivity and therefore reduce pain signaling to the brain. Treatment for chronic back and leg pain includes the use of traditional spinal cord stimulation, SCS, in which dorsal column fibers are targeted to reduce pain. Traditional SCS delivers strong low-frequency pulses to activate these dorsal column fibers, generating paresthesia, a tingling sensation that must cover the patient's painful area. Obtaining and maintaining paresthesia coverage for back pain can be difficult, leading to poor long-term outcomes. 10 kHz therapy has been uniquely developed as a more efficacious and paresthesia-free therapy. Rather than stimulating the dorsal columns, it is believed to work by more directly targeting the dorsal horn, using consistent lead placement proximal to the painful spinal segments and a high frequency of 10 kHz. The result is greater neural inhibition and thus greater efficacy. These frequencies all achieve only 50% responder rates or less, suggesting they cannot achieve the same levels of neural inhibition as 10 kHz therapy. Preclinical research into neural inhibition has shown 10 kHz stimulation can drive inhibitory neurons without meaningfully activating the excitatory neurons at clinically relevant intensities. This unique ability to selectively drive inhibitory neurons is not observed in testing of 1000 Hz or even 5 kHz. This unique mechanism of 10 kHz therapy is believed to be the reason for improved long-term efficacy versus all other SCS therapies. Looking forward, 10 kHz therapy's unique mechanism may also provide the versatility to more successfully treat.
So, obviously, that's a video that was produced by, let's see, how do I get back to that? Yeah, no, well, I mean, the reason I'm saying that is that,
There. Oh, is this where you are? But what slide?
I don't know, we can move, I'll figure it out. All right, so are we on this?
Yeah, let me actually get rid of this slide. Hide floating meeting controls. You're somewhere down here. There you go.
Thank you.
You're welcome.
All right, so the point of that was just to kind of give you a little cartoon about the different types of stimulation, and we'll talk about that. So traditional spinal cord stimulation, which has really been what we've been using until around 2014, before high frequency stimulation came out, it creates this paresthesia in the painful area. So with both of these different types, low and high frequency stimulation, you still put leads in the epidural space, but it's just what you're doing to those leads that differentiate the two. And when you stimulate the dorsal column, which is more superficial in the spinal cord, it creates these paresthesias or buzzing sensation in the back and legs. And for some patients, they find it helpful. And that's traditional spinal cord stimulation. High frequency stimulation is paresthesia free. Typically what's done is they use 10 kilohertz or 1000 hertz, and it affects deeper into the dorsal horn of the spinal cord. And as you can see there, those inhibitory neurons are stimulated by the spinal cord stimulator. And the thought is they inhibit these wide dynamic range neurons, and they're implicated in chronic pain. So we typically do a trial to see if a patient would benefit from a spinal cord stimulator, and you can essentially try it out before you get it. It's a minimally invasive procedure, and we evaluate them for about a week. We usually put them in on Monday, remove the leads on Friday, and they try it out, and if it's effective and it improves their quality of life, they get over 50% pain relief, they can get it put in permanently. It's an outpatient procedure. It usually takes anywhere from 20 minutes to an hour, depending on their spinal anatomy. That's usually done with local anesthesia, with a little bit of sedation, people are typically out pretty quickly, and they get to try it out right away. Here's just some images from a spinal cord stimulator trial. It's all done with X-ray guidance under sterile surgical conditions with prophylactic antibiotics. Use a loss of resistance technique. You can see these are larger, what we call Coude needles. And you get the needles in the epidural space using loss of resistance, same technique that are used for laboring women having epidurals. Once the needles are in the right spot, we put the leads in the epidural space, confirm that they're in the posterior epidural space on that lateral view. And then the needles are removed. And when the needles come out, you have the leads coming out of the skin. We tape that in sterilely and they hook it up to an external pulse generator that'll be given energy for the stimulation of the spinal cord. Here's an image of one of the patients that we did a spinal cord stimulator trial for painful neuropathy on. You can see the leads are taped in and the battery pack is kind of taped to the side of the hip. They're given a remote control. There's different programs. They work within the spinal cord stimulator representatives throughout the trial to go through the different programming and amplitude changes till they find a program that works well for them and their pain. For the permanent implant, that's done on a different date. The leads come out from the trial. You don't want to implant those leads. They're obviously a risk for infection because half of them have been outside of the skin. So for this procedure, we usually do them under general anesthesia with neuromonitoring. And I put the leads in the same manner in the epidural space. And then the leads are anchored to the fascia and tunneled under the skin to the IPG, which is essentially the battery pack above the iliac crest. So contraindications for stimulation, uncontrolled psychiatric disorders is one. All these patients are required to have a psychological evaluation prior to a trial. If they can't stop blood thinners, we can't do it. It's just too high risk for epidural hematoma. If they have any systemic infection, you obviously don't want to implant something in the spine. There are increased bleeding risk with either coagulopathy or thrombocytopenia. These are some of the contraindications. So complications, it's a pretty safe procedure, but there are risks. There's a risk of bleeding, infection, and nerve injury whenever you do injections in the spine. Epidural hematomas are very rare, but possible. And if that happens, patients may need to be treated surgically. For the permanent, the more common thing that happens is lead migration. So the leads may move a bit, even though they're anchored to the fascia, there's still some wiggle room. And usually there's enough leeway so that we can just stimulate at a different electrode and get good relief. Once we get the x-rays, we'll see where the leads move and just adjust the stimulation. Infection is possible, and it happens. About 2 to 5% of patients will get an infection. Some of those patients will need to be explanted. Sometimes we can save the device with IV antibiotics. The study that we'll go over looking at painful neuropathy in the diabetic population, which you would think would be higher risk for infection. And these were done on patients with A1Cs of 10 or less. So there were, you would think, high risk patients had about a 5% wound complication or infection rate. One of the things that patients will sometimes complain of is just tenderness over the battery pack. That's not uncommon. Like any electrical device or any electrical product, your iPhone or earpods, AirPods, whatever you use, anything technological can have failure for technical issues. You could have impedance problems, you could have electrode fractures, it could just be a bad product that fails and you need to replace it. So occasionally we'll see technical problems from the devices. So what type of stimulator works best? So throughout my career, I've implanted every type of spinal cord stimulator on the market, the Nevro, Boston Scientific, Medtronic, and Abbott. Nevro is the only high-frequency spinal cord stimulator. All the rest are low-frequency stimulation. And most of the data shows that spinal cord stimulation works regardless of high or low frequency, but the higher frequency stimulation, in my experience, works better. And also, if you look at the data, it does do better long-term. In my practice, there are much less patients that want to be explanted or have the device removed with high-frequency stimulation. Patients are much happier with it. Nevro is a company that does the high-frequency stimulation, and they have an exclusive patent. There was a lawsuit between them and Boston Scientific, went to the Supreme Court, and they had a patent on the frequency of stimulation. I guess, brilliant if you're a business person. But so it's not like they have a product that can do something no one else can. It's just no one else is allowed to stimulate at those frequencies. So no one's allowed to stimulate above 1500 hertz besides Nevro, and all of their data is on 10,000 hertz. Their patent expires, I think, in 2037. Both high and low frequency stimulation has been shown to give improvements in pain symptoms, but high frequency works better. Here's just some studies on painful diabetic neuropathy. And really there's this one big study on painful neuropathy with high frequency stim, and these other two smaller studies on using low frequency stimulation. And basically what was found is the high frequency stimulation got about 73-74% improvement in their pain. And on average, the low frequency was close to 50%. So they both worked, but high frequency worked better. And the quality of the studies for the high frequency was much better. It was about 200 patients studied in that one, where these others were maybe 10, 20, 30. So this is the big study on painful neuropathy, was done on about 200 patients. And these patients were followed over 2 years. And last year when I did this presentation, we had data at 18 months. The trial's been completed now. We have 24-month data, so I'll show you that. There are 216 patients in this trial with diabetes. They have pain of 5 or more on VAS scale, A1C of 10 or less, BMI less than 45. This was done at 18 centers in the US. And they were randomized into 2 groups. One group was given continued medication management, which most of these patients were already on. And the other was given the medication management plus a spinal cord stimulator. And at 6 months after the trial, the patients in the med management group were allowed to cross over to spinal cord stimulation, and 93% of them did. So inclusion criteria for the study. So you have to have painful neuropathy for at least a year or more. And the pain's got to be refractory to at least 2 medications, one being a gabapentinoid, either trying those medicines and failing from side effects or just not being efficacious, and at least one other medication, whether it's topical lidocaine, Tylenol, ibuprofen. Most of our patients have tried more than this, but that's the requirement for this study. They had to have a pain score of 5 or higher, and they have to be appropriate surgical candidates. So this is the 6-month data. Not surprising, the patients that just got continued medication management didn't get any improvement in their pain. The patients that had the spinal cord stimulator, that blue line, you can see their average pain score went from about 7.6 to 2.4 to 1.7 at 6 months. And at this point, at 6 months, those medical management patients were offered or allowed to cross over to the stimulator. And most of those patients took them up on that offer. 93% of them went and had a stimulator trial. So this is looking at all the data over 2 years. And you can see there's 2 graphs, but they both represent essentially the same groups. One is the group that had the stimulator placed initially. The other were the patients that crossed over and had a stimulator placed. And you can see that the spinal cord stimulation works really well. And it's not just a short-term placebo thing. We're looking at 2 years at these patients. And this is drastic. This is huge. These patients are miserable, and the quality of lives are a lot better from this. So when you look at the overall pain relief, 90% of patients with spinal cord stimulator implants were responders. And we define success with spinal cord stimulation as 50% relief or more. 50% may not sound like a lot, but when you're dealing with debilitating pain, it's life-changing. And this not just worked okay, this worked really well. About 2/3 of patients were profound responders that reported over 80% relief. And on average, 80% symptomatic relief is what was reported in these patients. Remember earlier, the number needed to treat with medications for painful neuropathy was, I think, 4 to 11. Here we're looking at a number needed to treat of 1.3. So this is by far the most effective thing for painful diabetic neuropathy that I'm aware of. Not saying we start with this, but I'm saying it's very effective. And patients that meet criteria, I think should at least know this is an option out there, and it should be offered to them if they're a candidate. So this is just a slide showing, pictures of patients reported reductions in dysesthesias. So on the top, looking at numbness, on the left is the baseline, on the right is at 2 years. So you can see there's improvement in numbness, tingling, burning, and cold. Now, the interesting thing on the right here that you'll see is all these patients were examined by neurologists with detailed exams at various points throughout the study. And about 2/3 of patients at 6 months, at 3 months, 6, 12, and 24, it kind of plateaued and stayed at that level. But about 2/3 of patients had improvement in their neurologic exam, and most of that was sensory. So they either had improved sensation with monofilament testing or diminishment in the area where they have the sensory deficits. And to my knowledge, I'm not aware of anything that's, with these patients, you're always telling them, we have gabapentin, it's never going to get better. There's nothing we can do for it besides these medications, and you got to live with it. But not all patients, but about 2/3 of patients did have improvement in their sensory deficits, and this may improve their, long-term risk. So again, sleep is a huge deal, and about 2/3 of patients, patients reported 2/3 improvement in their sleep disturbances. So this is one of the biggest complaints with this patient population, and it works very well for sleep. Neuropathic pain, you can see that their pain is diminished, which is not surprising, but that DN4 score, a 4 or higher is what's necessary to be clinically diagnosed with painful neuropathy. And at 2 years, half of these patients, they don't even have pain high enough to be diagnosed with painful neuropathy anymore. So it works really well. And one of the biggest things, most important things, when you're dealing with chronic pain population, it's rare to have patients that are satisfied, right? I mean, you deal with it all the time. It's a tough illness to treat. And we're looking at, at 2 years, these patients are about 90 to 95% of them are extremely satisfied with the relief obtained. So this is long-lasting, durable pain relief with a high patient satisfaction. Just a little bit about the study. There was about 94% trial success rate, meaning patients were trialed. The majority of them had a successful trial. Of those patients, 85% went on to get an implant. So you may ask, if it worked, how come not everyone got the implant? Well, a lot of these patients have comorbidities. Sometimes they have a new AFib and they're put on a blood thinner and they can't come off, or they have an MI and they have a stent and they can't come off the blood thinner. Sometimes people, they can do a trial and it works really well, but they just don't like the thought of having something implanted in their body, and so they don't want it done. So, but most of the patients that did have a successful trial did get implanted, and 154 patients were implanted in the study. And following these patients over 2 years, 92% of them were followed up at the 2-year point. So it was a really good study. They didn't lose too many patients. There were no major neurologic complications in any of these patients. No people were explanted because the device didn't work well enough. There were some infections, 8 of them, 3 of them resolved with IV antibiotics, 5 required explant. Just briefly, the foot ulceration risk. So there's this task force associated with the American Diabetes Association that recommends monofilament testing in these 4 spots of the foot to screen if patients are low risk or not for foot ulcers. And so you check these 4 spots on the foot, one on each foot, so there's 8 locations. And if they if they're insensate in one or more areas, then they're increased risk for foot ulcers. And interestingly, with these patients, you could see the baseline and pre-implant, about 20% of the patients were low risk. And in the spinal cord stimulator group, you can actually see, because of that improved sensation in the foot, now about 40% of them were low risk. So we had some patients that were higher risk for ulcers, and now they have improved sensation in their feet and they're lower risk. And so there's no long-term data looking at that yet, but this is really exciting. I can just tell you anecdotally, with these patients, they're walking better, they're more active, they're happier, and it wouldn't be surprising to me if their foot ulcer and comorbidity risk with that goes down over time. And again, same thing at 24 months. It seems to plateau. So what we don't see is a continual improvement in their sensory deficits. They kind of hit this early at 3 months, 6 months, and it kind of plateaus. And so one of the questions that we asked is, well, why is this? And there's a recent study that was done at UC San Diego, looking at specifically high-frequency stimulation and nerve fiber density, and to see what's the mechanism. Why are you stimulating the spinal cord and they can feel their feet better? So this is not a big study. This is a small study, but they took 6 patients and they treated them with 1 year of spinal cord stimulation with high frequency for painful diabetic neuropathy. And the patient underwent serial biopsies of the skin, the proximal thigh and distal leg. I think it was every 3 months, to evaluate intradermal nerve fiber density. And they found that pain relief and improvement in sensory function was accompanied by increased lower limb intraepidermal nerve fiber density. So they're sprouting more of these nerve fibers. We don't know why, but it seems that this is likely the case. And they recommended, further blinded, better controlled studies to confirm these findings. But this is interesting, and it provides potentially one of the pathways into why we see what we see. And this is from that study. You can just see that this is the baseline, and then over time, over 12 months, there was about 179, 180 increase in intraepidermal nerve fiber density. So these patients are growing more nerve fibers, and that may be one of the reasons why they're having improved sensation. A little bit about the FDA labeling. So spinal cord stimulation is FDA approved for treatment of failed back surgery syndrome, intractable back pain, leg pain. It is FDA. This study got it FDA approved for painful diabetic neuropathy. I'm not talking about some quacky off-label use stuff. This is FDA approved for painful diabetic neuropathy, and it works really well. There are risks, so we don't want to do it if we don't need to, but it is life-changing for a lot of our patients. So in conclusion, painful diabetic neuropathy, it's undertreated, it's progressive, it leaves a lot of our patients in pain, it's affecting their sleep and overall function. I urge you all to talk to your patients and don't just poo-poo it anymore, just realize there are effective treatments for it. And we're happy to see them and evaluate them to see if they would be a candidate for this. The pain is outside so some of the patients I take care of have painful diabetic neuropathy, and but it's really outside of the patient population I typically see. And so what I've been trying to do is really get out to the community that this is a real condition, we have very good treatments, and that this is an option. We've even been advertising on television because even though I reach out to medical providers, this is something that a lot of patients deal with, and they don't even talk to their doctors anymore about it, or their healthcare providers, because no one's really been able to offer them anything in the past besides gabapentin. So I urge you all to talk to the patients about it if they're complaining about their feet, and we can help these patients. It really is the most effective long-term treatment for painful diabetic neuropathy, refractory medical management. It's not just my opinion, the data is there for it. Life-changing for a lot of our patients. These are the happiest patients I see. All of them are home runs. I really enjoy this patient population. They are higher risk. Some of them have foot ulcers and other comorbidities, but if we can get those controlled and get them treated, they're extremely grateful. So please consider a referral for patients you feel may be candidates, and happy to answer any questions. Oh, here's the reference slide, Jason.
Yes, then other people can hear.
Yeah.
Testing. Hi, thank you for your talk. I have a question. I program deep brain stimulators for Parkinson's and ET. So there's research for Parkinson's, you can make a reduction in medicine up to about 50%, and for essential tremor, 30%. Is there some research about reducing? I mean, this is an opioid conference. So is there some research with the spinal cord stimulator at a year, 2 years out, that you could make a reduction in their pain medication?
Yeah, there's I didn't really touch on that. I took actually some of that out of this talk, but yes. So when you even this study, the painful diabetic neuropathy study found a reduction in opiates. We use spinal cord stimulation for a lot of different indications. The most common one is failed back surgery syndrome. People have back surgery, persistent back and leg symptoms. And patients, we definitely can reduce. That's one of the reasons why we do it, is because people want to come off of the opiates. So there's many studies that have shown a diminishment of opiate needs. It depends on the patient population. So like I said, we do it for totally different indications. Parkinson's, that's one indication, but we're talking about anything from, you know, back and leg pain to foot pain, and they're totally different. So I don't have it offhand specifically for painful neuropathy, but in this trial, there were more ER visits due to pain in the med management group compared to the non-med management group. And there was I believe, opiate reduction, but I don't have the number. Yeah. Yes.
Again, thank you for this talk. I specialize in diabetes, and I've definitely been in that trap of what do you do other than gabapentin? So thank you for this. This is a great option. I wanted to know, at the Apex Spine Institute, are you guys utilizing PRP at all for diabetic neuropathy?
Not for diabetic neuropathy. I'm always cautious about PRP, stem cell products. I try to stay with FDA-approved, you know, things, because a lot of that is out of pocket to the patients too, and I just don't feel right asking for a bunch of money for something that doesn't really have evidence. So I haven't used a PRP for neuropathy in the feet.
Is there any possibility that there can be a neuroreceptor dysfunction in pain pathways such that no form of oral or electronic treatments are successful?
Yeah, so I think pain in general, that's a good question. And it's something that's, I think, hard to study, but we have a select group of patients. I could probably think of 5 or 10 of my patients off the top of my head, where you treat nearly everything and they don't get better. They're spinal, you know, they have prior back surgery, they have classic neuropathic pain, and the spinal cord stimulator doesn't work. You try every other treatment. They've seen every surgeon in Eastern Washington and Western Washington. And so I think we're all wired differently, and I don't know what the mechanism behind that is, but there are certain chronic pain conditions, or certain patients that we really can't get much long-term improvement with interventional treatments and even medication management. So yeah, I think there's definitely something to that, but I don't know a lot of the molecular aspects of why that is.
Are these devices MRI compatible?
Yeah, so they are, and in fact, usually they just need to be checked to make sure their impedances are normal and there's no fractures in the leads, but they are MRI compatible, yeah.
Is there any role in this for restless leg syndrome?
Yeah, so we use it for other types of neuropathic pain. It's not FDA approved for restless leg syndrome, but a lot of people with restless leg syndrome also have peripheral neuropathy. And I've used it for non-diabetic painful neuropathy as well, and have had some success with it, but it's not, you know, FDA approved. That's off-label use. So yes, and the nice thing about it is you could try it out. And with the trial, it's really apples for apples. So you're putting those leads in, they're exactly the same leads that you would put in for the permanent, using the exact type of stimulation. So you are really giving them a good trial of how effective it will or won't be. And so for those patients, if they try it out, if it doesn't work, it doesn't work. But if it does work, then they may want to have it put in.
You mentioned the, refractory year, kind of what would be the criteria. I'm just curious, like, would it be accepted if someone had like CKD to the point they can't take some of those opioids, or they have hepatotoxicity? Could that be another, and chronic pain? Would that ICD-9 or 10 code go through, or is it pretty specific that it's got to be refractory for a year, failed to,
So are you talking about for painful neuropathy in the feet or
well,
for
for
just-
referral to spinal stimulator, like,
Oh, there's a lot of different indications for it, and in you know, as far as you know, so people with chronic pain. And so if you had someone like with chronic kidney disease, are you talking about like that they have back pain or?
yeah, they would be co-morbid, they'd have the chronic CKD, but I was wondering if that could be another indication because you really can't do your
Oh, I see
med
what you're saying.
management. You've kind of run up against
Right,
either
right.
hepatotoxicity or.
Yeah, so I think those
CKD.
are patients that we may evaluate earlier without. So if some patients, so for instance, for this study, in my practice, if I had a patient that had clear indications for a spinal cord stimulator, but because of other comorbidities, they couldn't take Lyrica or gabapentin, I wouldn't, I would just document it and go right to the trial.
Okay.
Yeah.
All right.
Hi, what about cost? Do insurance companies typically cover?
Yeah,
this?
so this is FDA, you know, approved. It's covered by Medicare and most insurance companies. There are a few that we have to go up the ladder and appeal it because it's not an expensive. I mean, it's not a cheap treatment option. And so, you know, most insurance companies, their default answers for no, anything you want to do for a patient that costs money. So you kind of have to fight a little bit, but. I would say over 95% of the time we can get it authorized because we're doing it for medically indicated patients. Yeah, it's well proven. And in fact, our state is the only state in the whole United States of America that currently doesn't cover spinal cord stimulation for work-related injuries. But around June, that's probably going to change. They're going to announce it and get the indication. So even LNI is going to start covering this. Yeah.
That was my question, but
Yeah.
so the second question would be a ballpark, what does it usually cost? Because I see a lot of self-pay patients, so just out of curiosity.
I've never seen a self-pay patient for a spinal cord stimulator because it's expensive. You know, there's just the device itself, it's about as expensive as a car. I mean, it's like a $20,000-ish to purchase the product to implant in someone. So it's not cheap, but you know, sometimes some spine surgeries can cost $200,000. So it's not, and we look at the long-term cost, even of chronic opiates, with all the doctor's visits and the drug testing and the ER visits, and you know, it's if we can really get their pain controlled. You know, if I had to pay cash for it, and if I needed it, thankfully I don't need one, but I probably would if I felt it would change my life a lot. But again, I've never had a cash pay patient because it's always approved by the insurance company because we're doing it for proven indications.
Have they studied other peripheral neuropathies that can cause pain as well?
So as far as spinal cord stimulation, or is that a question?
It's a question online, so I don't know.
Okay, so yes. So as far as spinal cord stimulation, I think what they did with this painful diabetic neuropathy is, you know, these companies, it's all business, right? And so they want to find the biggest patient population that they can get to. But I see a lot of patients with non-diabetic painful neuropathy, and we'll kind of treat them under this umbrella, given the data that we have for diabetic neuropathy. Even though they're not diabetics, they have the same, you know, conditions. So, but is it hasn't been, you know, studied in large prospective trials like this for any other type of neuropathy population that I'm aware of. Well, neuropathy is a very broad term, so I guess I mean you could, yeah, it's been studied quite a bit on neuropathic pain in the legs and feet, especially in the setting of lumbar radiculopathy, failed back surgery syndrome, that sort of thing.
My question is, once we make a referral to see you,
Mm-hmm.
how many appointments would these individuals have to come?
Yeah, so usually I try to see these patients myself because I really like this population. I want to make sure that that they're being treated appropriately. And so what I usually do is evaluate them. There was just someone I saw yesterday that's never tried gabapentin, and so of course, we're not going to do spinal cord stimulator. I prescribe him gabapentin and we're going to see how he does. And I have had other patients that we try the gabapentin or Lyrica and they do real well. And that's all we need to do. So we evaluate them. And some people, they feel like, oh, I don't know if I should send them because I don't know if they're, they're diabetic and, they've had foot issues in the past, or, I don't want to send someone that's not a candidate. It's, I just want to take care of the patient and do our best to help them with their pain. Maybe half of the patients won't even need a spinal cord stimulator, but we can evaluate them. That's not, our role is not to stick stimulators in everybody, but it's to evaluate them and give them the best treatment available. Yeah.
So if you do opt to get a stimulator
Mhm.
placed, how often do they have to come and see you again?
Yeah,
Every
so-
6 months, every?
No, so there's a bit of a process before the trial. So before we do a spinal cord stimulator trial, we got to look at their spine. We got to get MRIs of the mid back and low back. They have severe stenosis. You don't want to be putting a device behind the spinal cord to cause a spinal cord injury. So we have to image their spine. So if we see a patient and they meet all the criteria, they're a good candidate. We talked about the stimulator. They're really excited. They want to go. I order the MRI scans. We get some X-rays. We order the psychological evaluation that can be done over the telephone. Then when we follow back up, we go over all the imaging. We go over the psych eval. We talk in more depth about the stimulator. And if they want to move forward, I order it right there at that visit. We work on the authorization. Then they call the patient, schedule the stimulator trial with the patient. We do it on a Monday. The device comes out on Friday. They see us at that follow-up on Friday. We remove the leads. And if it's successful, we get them set up for a permanent implant.
So since most of the research and the FDA approval is for spinal conditions and for diabetic peripheral neuropathy, do you find that there's coverage issues with idiopathic peripheral neuropathy?
With Medicare, it's not as much of an issue because there's such a broad spectrum of diagnosis codes currently that you can use this for. You can use it for postherpetic neuralgia, for non-specific mononeuropathy or other neuropathy. But with the commercial insurance companies, some of them are more selective about coverage. So that's where we'll run into the issues, and we'll have to do appeals and go through multiple levels. Sometimes you have to have them send it out to an external reviewer, but usually after enough appeals and letters, we can get it covered.
Quick question about the anticoagulation. Is it just to hold around like procedurally, or is the risk of bleeding while they have the leads in
Yeah,
period?
good question. So typically what we do, because even removing the leads can theoretically cause bleeding. And so if people are on, say, Xarelto, we have a certain time frame. American Society of Regional Anesthesia puts out guidelines. You stop the Xarelto, I don't know offhand, we have, I think it's 3 days, 4 days prior to the procedure. Do the stimulator trial. When the leads are in, we continue to be off the Xarelto, remove the leads, restart the Xarelto 24 hours after we remove the leads.
Wonderful questions. Great answers.
Thank you all. Yeah.
Thank you, Dr. Schuhan.